it's wonderful he's here as Dr. Abe Alexander, and he has spoken here a number of times, and we're delighted he's back with us tonight. He's a radiation oncologist and clinical assistant professor at the Cancer Agency here in Victoria. His areas of interest include genitourinary cancers, which include prostate cancer, as well as brain tumors, gynecologic cancers. He performs external beam radiotherapy, brachytherapy, stereotactic radiosurgery. His areas of interest are clinical research, which includes novel radiation techniques for prostate cancer, such as prostate SABR, I'll tell you what that means shortly, hormone therapy research, and brain tumor outcomes. Some of those words are a mouthful for me. His topic tonight is new treatments for prostate cancer, Radium 223, or 223, I'm not sure how I would say that, and prostate stereotactic ablative radiotherapy. That's what SABR is. So now we've got some idea of what it is. So welcome, Abe Alexander.
Thank you all for coming. I appreciate the opportunity to speak with you all today. I wanted to talk to you today about some of the more recent advances or recent additions that we have at the Cancer Agency in terms of prostate cancer treatments. 2016 has been a great year in terms of new treatments coming out, and Vancouver Island Centre being able to adopt some of these new treatments. And in particular, there's two, I would say, exciting new treatments for prostate cancer that we're now able to offer at the Vancouver Island Centre that I wanted to talk to you about. One has this very long, complicated name. It's called Prostate Stereotactic Ablative Radiotherapy, and basically we just call it SABR, is what we call that. And that's a new treatment that we have available now, and it's for treating potentially curable prostate cancers that are localized, haven't spread. We also have a new treatment called Radium 223, and that's a treatment for men who have prostate cancer that is treatable but not curable, and men who are in the phase of treatment where the cancers are no longer responding to the normal hormone therapy. And so that's a very difficult phase of the disease to treat, and so it's really fortunate that we have a new agent that is really helpful for men in that situation. And then, so those are the two new treatments that we've been able to offer now at the Vancouver Island Centre. The third thing I was just going to mention is a new product. It's not something that we have available in 2016, it's more on my wish list for 2017. It's a new product that's now available and that we're trying to get in for 2017 that's being used elsewhere to reduce radiation treatment side effects, which I think is of particular importance in this field. So I'm going to start by just mentioning, I'm going to start by talking about the SABR, so the Stereotactic Ablative Radiotherapy. And this is actually one of the most exciting areas, and certainly in prostate cancer radiotherapy, and actually in all of radiotherapy. I'm going to talk to you about SABR and how it applies to prostate cancer, but actually it's a type of radiation treatment that is being applied across the board in my field to all different kinds of cancers, lung cancer, kidney cancer, brain tumors, and is really changing the way that we treat things and really improving our chances of controlling tumors at all different sites and really reducing the amount of side effects that we give to people in the process. So before I talk about it, I just thought I'd mention some of the current treatment options for prostate cancer. Basically, I'm sure most of you are familiar with this. For men who have prostate cancer that's localized, so potentially curable prostate cancer, there's really three main treatments, standard treatments that are available. Some men opt to have surgery, what we call radical prostatectomy. There's also prostate brachytherapy, which I'm sure some of you are familiar with, where we surgically implant radioactive seeds into the gland, and it's sort of radiotherapy sort of from the inside out. And then the last is external beam radiotherapy, where men are treated with radiotherapy using an external radiation machine to kind of zap the prostate from the inside. These are, considered, pretty much worldwide to be the three standard treatments for prostate cancer. They're all excellent treatments, but none of them is perfect. Surgery or radical prostatectomy gives excellent outcomes, but it is an operative procedure, and it's not a small operation. It's a fairly substantial surgical procedure, and as such, it can be difficult for some older men or some men that have other comorbid health problems, and so it's not really appropriate for many men because of that. And also, most men do very well, but, urinary incontinence or having some leakage from the bladder can be a problem for some men, up to 5 or 15% of men in the long term after having surgery. Prostate brachytherapy is the other a very excellent treatment that also produces excellent outcomes, but it too is an operative procedure. It's an operation, albeit a much smaller operation than the prostate surgery, but it's still invasive, still requires undergoing an anesthetic, and so therefore often isn't appropriate for men who have other health problems or other issues going on. Also, in terms of side effects, most men do very well with brachytherapy, but some men do have problems, and certainly somewhere between 5 or 15% of men will have troubles in the long run after brachytherapy with their poor stream, frequent urination, and things like that. The external beam radiotherapy, the last one, that's probably the easiest treatment for men in terms of side effects. It's non-invasive. There's no surgery, no cutting, needles, nothing like that. It's very simple, and in terms of side effects, it's generally considered to be very mild in comparison to the other two for most men using today's technology. The biggest downside to the external radiation treatment, however, is it's inconvenient. And I'm sure I recognize some faces around the room for people who've had external treatments before. These days in the Vancouver Island Centre, men having external beam radiation treatment are basically looking at coming in most commonly for 37 treatments, given one treatment a day, Monday to Friday. So they're usually looking at about 7.5 weeks of treatment, sometimes more. And if you go down to the States, it's often as many as 44 treatments over 8 or 8.5 weeks. So it's a great treatment, but it's not very convenient. It's not so bad, I suppose, for men who live in Victoria. Certainly if you live on island, if you're living in Nanaimo or Courtney or something like that, you're basically looking at coming down to Victoria and setting up shop, living here for 7 weeks or 7.5 weeks to get your treatment, which is difficult. It's not easy for other men. So it would be nice to have another option, and this is where SABRE comes in. So again, it's called Prostate Stereotactic Radiotherapy. And basically what this is, SABRE, it's a form of external beam radiation treatment. But what it is it's a very precise, very accurate, and very conformal. What I mean by conformal is very focused form of external radiation treatment. And so with SABRE, because it's so precise, accurate, and focused, you can reduce the number of treatments. So instead of a man coming in for 37 or 39 treatments, it can be delivered, of course, treatment can be delivered in 5 treatments, so a very small number of treatments. But that being said, each individual treatment is much larger. So they're 5, instead of having 37 small treatments each day, it's 5 treatments of a much larger radiation dose on each day. So definitely you can see the appeal there. I mean, it's much more convenient for men who want external radiation treatments and from Up Island. The way we're doing it right now is 5 treatments, given 1 treatment a week for 5 weeks. So, if someone from Up Island, you don't have to stay in Victoria anymore. They can come down, get their treatment on Monday, go back home the same day, and then just come down again the following Monday and do this 5 times in a row. So it's certainly much more convenient. And it has a couple other advantages. From a scientific point of view, there's a lot of data suggesting that when we give fewer but larger radiation treatments, that strategy actually might be more effective against tumor cells and might actually be easier on neighboring organs, the normal cells, things like the bladder, the rectum, things that we don't want to damage. The problem is when you're giving a small number of large doses of radiation to the prostate, a high degree of accuracy is needed if you're going to do this safely. You can imagine these are large radiation doses that we're delivering on any given day, and if we're not, really accurate, really precise, and really hit the mark properly, not only can we compromise the control of the disease, but we can also cause damage to the neighboring organs and make things worse for men. So, excuse me, I apologize there. And so this is a machine. It's typical kind of radiation machine. It's not the exact same machines that we have at the cancer agency right now, but it's very similar. And it's a typical radiation machine that's capable of delivering this form of radiation treatment, the SABRE. And what makes it, it's like a regular radiation machine in a lot of ways, but it has a few bells and whistles that allow us to give this more precise treatment. And I'll go through some of those, where you can kind of see sort of on the top here, for those of you who've never seen a radiation machine before, the patient lies on the couch here, this is the table, and the radiation machine, the radiation beam comes out of this part, the gantry. And then what makes the units that can deliver this kind of SABRE what makes them different is they have a few bells and whistles. One of them over here is a CAT scanner, and what that is allows the patient to be scanned while they're before, during, and after the radiation treatment to allow things to be more precise. So that's just what the machine looks like. So how does Prostate Saver work? Basically, there's 3 components to it. The first component is basically you have to aim the beam correctly. It's a matter of aiming the beam very precisely at the target that you want to hit. And so basically what that means is you need to really set up the patient very accurately each day, and you need to target the prostate very accurately each day. And I'll go through each of these individually. The second thing that's required for Prostate Saver is to have a way of delivering the radiation treatment that is what we call highly conformal. And what that means is very focused, so that the radiation is focused on the areas you want, in this case the prostate, and is away from the things that you don't want to give radiation to. So that would be, for example, in this case, the rectum and the bladder. And then the last thing is, if we're going to try and deliver radiation in this sort of precise fashion, we have to make sure that we hit the target. You know, we don't want patients to move while they're on the treatment. If the beam is on and the patient moves, then we're not hitting the target anymore. And you may be surprised to know that even when you're lying still, the prostate gland itself moves. You know, it moves up and down when you're breathing. Its position changes depending on what your bladder and your bowel are doing. And so we need to take all these things into account to make sure that we actually hit the target once we've already aimed the beam and started treatment. So how does this work then? So in terms of setting patients up, and actually the first step, which is making sure that we aim the beam correctly, the first step is to make sure we set the patient up and target the prostate gland accurately. And we do this in a couple of ways. One way is before someone starts this kind of radiation treatment, we do a procedure that's kind of like a biopsy. Basically, we freeze the area down in the pelvis and use a needle to put 3 tiny little gold seeds into the prostate. And the reason we do that is, and you can see this on this film, those 3 little seeds are the white dots there. You see that where the green X's are, just next to them are 3 little white dots. Those white dots are the seeds that we put in. And by putting these 3 little seeds in the prostate gland, when we're setting someone up on the radiation machine each day, we can see where those seeds are, and we know that they're in land, so it gives us something to aim at. And so that's sort of the first step. The next step that goes along with that is there's a special table. The table that the patient is lying on isn't just a regular table, it's what we call a robotic couch. And what that means is, when a patient is lying on the table, basically, going back to this picture, the white dots are where the seeds are in the patient. The green X's are where those seeds should be if the patient is in the right place to get the treatment. And as you can see right now, they're off by a little bit. Those green X's don't sit right on top of the white dots. So this patient isn't perfectly set up. The beam isn't aimed exactly correctly. And so what the machine does and what the computer does is it takes that into account, and then the table that the patient is sitting on actually moves automatically in whatever directions it has to go, up, down, in, out, tilt, yaw, roll, all different directions. It moves the patient in whichever direction it has to, by however much it has to get those green X's to line up with those white marks. And when that happens, that means that the person, and that means the prostate, is in the right place for the radiation treatment. We've targeted the prostate appropriately. Then the last thing is we want to make sure that we targeted the prostate appropriately. And so once we've got the person set up, we've got these green X's on the white dots and everything, we want to make sure and confirm that. And so that's where the CAT scanner that's attached to the machine comes in. A CAT scanner is basically, just gives us fancy 3-dimensional X-ray pictures of the pelvis. And so that tells us where the prostate is and makes sure that it is where we think it is. And this is just an example of a CAT scan image. And basically, I mean, what CAT scan images are pictures in cross-section. So as if you cut somebody this way and you're looking down at them. And so basically this blue contour here, that's the prostate gland. This little white dots here are the seeds I mentioned, and behind it is the rectum. And this scan is a kind of a backup to make sure that, yes, indeed, before we turn the beam on, the person is in the right place and the prostate is in the right place, so we're hitting what we want to, and we're not hitting things that we don't want to hit. So so that's the first step. We've aimed the beam. Now we have to give the radiation treatment. And this part is a bit complicated, but basically now it's a matter of delivering the radiation treatment and making sure that it's focused on the target. And this part is very complicated, but it uses what's a very a very complicated way of delivering radiation. It again has another fancy name. It's called volumetric modulated arc therapy. We call it VMAT. And basically what that means is when a patient is lying on that table, the X-ray machine will rotate around and make an arc around the patient, 360-degree arc around the patient, and the beam is on the whole time, and that beam is changing and doing things as that machine is rotating around. It's very complex, but at the end of the day, what it all comes down to is it delivers this. And that's the same CAT scan picture, and what this shows is where the radiation is going. So this red line here is the prostate gland that we want to treat. And these colors, this kind of green-yellow color, that denotes where the high dose of radiation is going. And so basically, if you look at this picture, with this kind of radiation delivery, we've got a high dose of radiation where the prostate is where we want it, and it hasn't delivered a high dose of radiation to other things, in this case, the rectum back here, or the bones, or the muscles. Basically, it's focused the radiation where we want it. So that's the second part. Now we've aimed the beam, we've delivered, or we're in the process of delivering radiation to this patient in a highly focused fashion. The last thing is we got to make sure we actually hit the target. And what that means is we want to make sure we want to do something to minimize this patient moving on the table and minimize the prostate itself moving on the table while the radiation beam is on. And there's many ways to do this. And different centers will do it different ways. The way we like to do this is basically by delivering an ultra-fast treatment. And so again, we use some of the fancy bells and whistles that come on these radiation machines, such that the radiation treatment is so fast, we're hoping that there isn't time for the patient to move in that sort of short period of time. And so with this treatment, with the SABRE treatment, the patient is on the bed for only 60 seconds. That's how fast it is. So if the patient just has to lie on the bed for 60 seconds, and that large dose of radiation is delivered where it should be. It is possible in that very brief treatment that someone can move. Fortunately, we've found that doesn't seem to be the case in the cases we've done so far. That being said, we do want an added kind of safety net around this. So we do have some new equipment coming, and that's this sort of coming soon thing down at the bottom. We've purchased this sort of fancy system, which is basically, if you look up here, this little camera thing on the ceiling is a fancy optical monitoring system, and what it does is it's constantly monitoring the surface of the patient, and that way if the person on the table moves even a millimeter, the radiation beam stops. And then we put them back where they're supposed to be and turn it back on. So it's kind of a final safety check to make sure that the person's not moving, that they are hitting the target. That system's not up and running yet. It should be up and running within a couple of months. So after all this, does it work? You know, is prostate SABRE worth all this fuss? And I think it is. It is still considered experimental. It wouldn't be considered a standard treatment for prostate cancer at this point, but it's being studied, you know, in many places around the world, and the early data would suggest that it works very well. In patients with what we call low-risk prostate cancer, so the sort of slow-growing type of prostate cancer, the studies would show it has about somewhere between 97 and 99% success rate 5 years after treatment. For men with sort of the medium-risk disease, sort of maybe closer to 90%. And for men with a higher risk disease, we don't know yet. The studies haven't gone there yet. So we're still working on that. And what we don't know is how does it compare with regular radiation treatment, the conventional sort of 37 or 39 treatments. We don't know yet. Those studies are ongoing. From the studies that have been done, it appears so far that the side effects of prostate SABRE are at least comparable to the side effects someone gets with regular radiation treatment, and probably more favorable. And in terms of how well it controls the disease, we think, from what we've seen so far, it seems to be at least as good as regular radiation treatment, probably a little bit better. But no one's reported any studies directly comparing SABRE with regular radiation treatment yet. But we're working on it. And this is the study that we're doing. So this is a study of prostate SABRE that's open in BC. It was written up by a few of us at the Vancouver Health Center, and working with some of the oncologists and some of the other centers. And basically, this is what we call the ASSERT study. And basically, it's a study looking at prostate SABRE and comparing it directly to conventional external beam radiation treatment. And this study is meant for men with sort of the higher risk sorts of prostate cancer, so the radiation treatments, either one, whether a man gets the stereotactic or the SABRE, or whether they get regular radiation treatment, both of them are given with hormone therapy, as is common when we are treating higher risk disease. It's a randomized study, so if someone who wants to go on it, I can't guarantee them they'll get the saber. It's a coin flip, it's 50-50. If you flip heads, you get to get the prostate saber. If you flip tails, you get the regular radiation treatment. So this study is open right now at multiple BCCA centers. It's for men with the kind of middle and high risk prostate cancer. And as I mentioned, it's random. So the guys that get the saber get 5 treatments once per week, and the regular radiation treatment men get 28 treatments over 5.5 weeks. And so our hope is with this study, we'll actually get some answers on how effective is saber compared to the regular treatments, and how do the side effects compare with the regular treatments. So far, we've only been open, the study's only been open since May, and so far we have 16 patients on the study. Because they get hormone therapy first, not all of them have actually had their radiation treatment yet, but 6 people have completed the treatment so far, and from what we've seen so far, the guys that have been getting the saber are doing very well, phenomenally well. In fact, 2 of them I saw the other day, and both of them commented to me that they felt like they were getting a placebo treatment, because they were just finding they were getting so little side effects. They were asking me whether the needle was actually on. So it's certainly encouraging. So that's the saber, and so I'll stop there for a minute. If anybody has any questions, go ahead and pipe up. Happy to answer any questions. If not, I'll move on to the next treatment. So this is the...
Just one question.
Go ahead.
You said this was compared with 28 regular treatments.
Yeah.
Now, some of them last 37, I think.
So yeah, there are, in terms of the regular radiation treatments, so conventional radiation treatments, there's a number of different schedules, and which schedule someone uses, an oncologist recommends, is based on their personal preference and a few other factors. And so most radiation oncologists at the VIC generally recommend a 37-day course of radiation treatment. Personally, I favor a 28-day course treatment, so that's what I usually recommend. And so it varies from site to site. So, but you're right, the majority of men are given a 37-day course. I generally tend to use for you.
So how long will this study have to go on? Probably about 5 years before you can really determine the success.
So yeah, I mean, we hope, because we're not the only ones running the study. It's right now it's being run in Victoria, Fraser Valley, and then soon pretty soon Kelowna and Prince George centers are also, and Abbotsford are also going to be opening up. So there should be 5 centers participating in the study. So because of that, we think we'll be able to get all the patients, the 80 patients, very quickly. I'm pretty optimistic that within a year's time we'll have gotten 80 patients and have them going. But you're right, in order to get a result, it will be about 5 years before we get our kind of preliminary results on how it goes. That being said, we do monitor, for safety reasons, we monitor every 6 months to make sure there's not any kind of nothing funny going on.
This might be a silly question, but what if the prostate has already been taken out and the cancer is spread into the bone? Can you also use this method for the bone?
You can actually, and that's a really another really exciting area. I mentioned that saber. I was talking about treating it for prostate cancer, but it's actually being used, or looked at widely in my field in different areas. And using the saber technique for bone is another thing that we're looking at. There's some studies that would suggest using a saber technique for bone is more effective at relieving pain and causing and those sorts of things than regular radiation treatment. The other thing is it's opening up a whole new area that we've never really delved into before. It's the whole idea of whether or not patients that, we've always classically thought that if their cancer is spread, it's incurable. And now we're starting to wonder, well, if the cancer is only spread to maybe 1 or 2 spots, if we use saber on those 1 or 2 spots in the bone, can we cure the cancer? And it's a whole new way of thinking that's different than we've been paradigms for 50 years or longer. That maybe there are some people whose cancer is spread who may still have curable disease if you treat it aggressively enough. And so certainly that's something that we're looking at. And we're actually opening another study for that probably within the next few months for men who have cancer that has spread to maybe 1 or 2 spots, using saber to treat those 1 or 2 spots in the bone and see if we can still cure things there.
If the cancer's gone outside of the prostate,
Mhm.
you have radiation treatment to begin with, and it starts coming back,
Mhm.
will this treatment be possible as a?
Yeah, and that's what I was just alluding to, is that, it would be, it would depend where it came back. So if we treated the prostate and it comes back, say, in a lymph node somewhere, or it comes back in a bone somewhere, the same strategy could be used. And you could treat, someone had a small number of areas where the cancer has popped up, you could potentially treat it with SABR. Whether it's good or not, we don't know. This is the things that we have to study. Whether it's worthwhile to do that or not, nobody knows the answer to that, but we're opening a study province-wide actually to look at exactly that question.
One other question. When was this technology developed and how long did it take to arrive locally?
So it's been, it's been a sort of a slow progress. I mean, what made SABR available is the advances that our field has had, mainly in terms of computer technology. Computer technology is always, advancing. As computer technology advances, our ability to plan more complicated radiation treatments improves. And the other area is imaging technology. Being able to make smaller CAT scans so that they can fit onto the radiation machines and these sorts of things. I would say that the technology to do this treatment has been around for, I'd say, since about 2004. But at that point, it was highly, highly experimental. It's only, and so, I'd say that it's only become sort of more common maybe in the last 5 years. So, I think that BC, in Canada, we're still amongst the, I wouldn't say we're early adopters, but we're sort of in the middle ground. Certainly out east in like Toronto, they were kind of more early adopters of this kind of technique.
How do you figure out where to put the seeds?
So it actually not as hard as you think. We just we want to put the seeds in the prostate and make sure that they form a nice triangle. And it's just the way the geometry works out. If the seeds form a nice triangle within the prostate gland, then the computer can figure out where things are from them. If you bunch them too close together, it's not very good. If they're, so that's basically what we do. Yeah.
The improvement in this technology is mainly on positioning and controlling position, or is there other aspect like the beam size control and energy control?
Both, actually. So the part of it is the positioning of the patient and accurately being able to know where they are and that they're in the right place. But actually, I kind of glanced over the radiation delivery part. That was another advance that came along in parallel, this, what I call this VMAP, this very advanced way of delivering radiation treatment. That advance also allowed for it because it's such a great way to deliver radiation treatment in such a focused way. I kind of glossed over it because it's so complicated. It's an extremely complicated technique. Actually, interestingly enough, this very complicated, this radiation delivery process, which is called VMAP, which is basically used all over the world now because it's one of the best ways to deliver radiation treatment, was actually invented by Dr. Otto, who was a BC Cancer Agency physicist. I think he lives out in Salt Spring Island right now, but he invented the technology and it's used pretty much in the whole world nowadays as the preferred way of treating things.
Is hormone therapy still used along with the SABR?
In this study it is, we are still following the regular sort of guidelines and because we don't know, if the SABR is, more effective enough that you don't need it. We don't really know the answer to that question. So we're following the regular guidelines. People who would be given hormone therapy with regular radiation treatment, right now in the study we're giving hormone treatment with the SABR. In the future we may find that it's less needed for certain patients with the SABR, and we'll have to take kind of a step at a time. Is there more?
So is there a change also between the regular therapy versus the SABR?
Is there a change in what, sorry?
The radiation source.
No, the radiation source is the same. It's still what we call a linear accelerator, so it's the same type of radiation machine, but it's just this more a newer machine that has, it's basically able to deliver radiation in a more efficient and effective manner, and the imaging capabilities of the machine are different. But the actual source of the radiation is the same source. But only newer radiation machines would be able to be capable of delivering it. There are other names of it too, I've mentioned. Like some of you might have read other names for prostate SABR. A common one you might have read in the internet and things is CyberKnife. That's kind of a common one that's used, a type of machine that's used to deliver prostate SABR in America. There's many, many different machines that can deliver SABR. CyberKnife is the one that people hear about the most, but these other machines, what we call beam, are able to deliver as well.
How do you know if it works? Is it the PSA, or how do you know that it's succeeded?
So that, as with any treatment for prostate cancer, right now we use PSA as a response to treatment. And so basically, as with when someone has surgery, we use the PSA as an indicator of whether it works or not, because the PSA should go to 0. And with radiation treatment, it's the same thing. There's certain behavior that the PSA should have after treatment. It should basically go low and stay that way. And so it's the same with this. It does have a few little differences when we give these high doses. We do find the PSA kind of bounces around a bit more initially.
Yeah, I know a lot of people who've had it. I mean, not had treatment, but the PSA doesn't always go to 0. It may stay, but it stays below 1, or it stays below half, or is there kind of a number that?
So there isn't, officially, I guess it depends on what treatment you have. So if you have surgery, for example, after surgery, basically the PSA should go down to 0 and stay there. And if it goes up from 0 or close to 0, then that probably suggests that there's some cancer there. Certainly if it goes up past 0.2, that's what we would consider for certain recurrence. With radiation treatments, it's a bit different. With radiation treatments, the number we use for research purposes and stuff is if your PSA goes 2.0 above the lowest it ever got. So if after treatment your PSA went down to 0.5, that's the lowest it ever got, then we would consider your treatment to be a failure if your PSA subsequently went up to, say, 2.5. That make sense? So maybe if nobody else has any questions, I'll move on to the next treatment. And this next one I think is really important, and it's called Radium-223, and it's a whole different type of treatment. And this is a treatment option for men in a much different situation. And the different situation is what we call castrate-resistant prostate cancer. And what castrate-resistant prostate cancer, basically that's cancer where if someone has cancer that has spread, or if someone has cancer that has come back after treatment, that's a situation that's considered incurable, but treatable. And these days we treat that with what we call hormone therapy. I think most of you have heard of hormone therapy. The official name of hormone therapy is androgen deprivation therapy, or ADT. And so men who have this cancer that's spread or cancer that's returned, initially we treat them with hormone therapy, and it works. It works very well. That's why we use it. It works very well usually for a long period of time. But at some point, men who are on hormone therapy for cancer that has spread or has come back, at some point the cancer gets wise to it. At some point the cancer gets smart to the hormone therapy and learns to grow despite the hormone therapy. And when that happens, we call that castrate-resistant prostate cancer. And that's just because that means the cancer is resistant to medical castration or physical castration. When cancer, that's a difficult phase of the disease to treat. When cancer becomes castrate-resistant, it's basically resistant to our most effective treatment, hormone therapy. And that's when men start to suffer more significant problems with the cancer. So it's sort of it's a really important phase of the cancer for us to develop new treatments for. Right now, for men who are in this phase of the disease, the castrate-resistant phase, until recently we didn't have a lot of options. And then fortunately in the last 10 years, 4 or 5 new treatment options have arrived for this phase of the treatment, and one of them is Radium-223, which we've just gotten in BC within the last year. And so basically, men who develop this castrate-resistant or hormone-resistant prostate cancer, usually the cancer is progressing and showing up in the bones. And that's what this picture denotes. This is the bones again with somebody with prostate cancer, and all these dark spots are the prostate cancer showing up in various bones. Most men who develop this castrate-resistant prostate cancer, more than 90% of them, their biggest problem is with cancer that's gone to the bones, and usually many bones or multiple bones. And that's bad. That's bad for men. It causes a lot of problems with pain, it causes problems with fractures, disability, decreased mobility, and eventually leads to death. And so what Radium-223 is it's a treatment that's targeted to bone. And so this is what it is. Basically what Radium-223 is it's an injectable form of radiation. It's a compound that gets injected into the bloodstream, and once it gets into the blood, it pretends to be like calcium. And as all of you know, calcium is a component that is a mineral, a metal that we get in our food, and it's a component of our bones. And what radium does is it kind of pretends to, it's very similar to calcium, it kind of pretends to be calcium, and it gets incorporated into the bones in areas where prostate cancer is residing. So if there's prostate cancer that's spread to the bones, it gets incorporated into the bone in the areas where the prostate cancer is. And so that's what this picture shows here. This is the bone here, and this is where there's cancer in the bone. And the radium travels through the bloodstream and gets incorporated into the bone in the regions where there's prostate cancer. And once it gets there, it gets incorporated in the bone, it releases a very, very short-range particle of radiation. It's a special kind of radiation that we call an alpha particle. And what's really cool about alpha particles is they don't travel very far. You know, on my radiation machines that we use to treat people, those beams go right through you and out the other side. This type of particle, an alpha particle, it travels very, very short distance. When, we're talking a fraction of a millimeter, it doesn't go very far. And so the good thing with that is this alpha particle will then get released by the radium. It will hit the bone cancer, the prostate cancer tumor cells in the bone and treat it, but it's short range enough that it doesn't go anywhere else. It doesn't get far enough to cause much side effects. And the side effect we worry about is the bone marrow. Inside your bones is the bone marrow, and that's what produces the blood cells in your body, your white blood cells, your red blood cells, your platelets. And so this radium is able to effectively treat tumors in the bone without affecting the stuff in the middle of the bone marrow, so it doesn't impair your body's ability to function normally. So it has a very favorable side effect profile. It works very well for patients who have this kind of cancer in the bone, and it's given as an injection once per month. So you just come in, you get your injection, you go and then come back next time, and we generally give it for 6 months. And it has been studied, and so this is, I'm just going to show you some slides to tell you what the benefits are. This was studied by a huge study where they gave half the men this radium treatment and half the men placebo, and tried to see how well did people do. And what they found is that men who take the radium treatment live longer than those who got placebo. So men taking the radium was shown to improve the overall survival of men with castrate-resistant prostate cancer. It was shown to men who got radium are less likely to suffer bone problems from their prostate cancer, such as fractures or the need for surgery, as compared to men getting placebo. And patients who are getting radium are less likely to need narcotic pain medications, so things like morphine or hydromorphone, because their bone disease was under better control. And I think what I think is most important is quality of life. Increasingly we're finding in cancer treatment, we want to measure quality of life with our treatments, and that's the most important outcome. And radium has been shown to improve people's quality of life over placebo who are in this situation. So now radium-223 is actually one of the standard treatments that we have in BC, in the Vancouver Island Center, for men with this castrate-resistant or hormone-resistant prostate cancer. And it's worked very well here. This just started in the last year. This is a partnership between the BC Cancer Agency and the Vancouver Island Health Authority, because we see the patients, eligible patients are seen by us at the Cancer Agency. We recommend the radium, we prescribe the radium, but the medication is actually given at the Royal Jubilee Hospital by the Nuclear Medicine Department. So it's really been great working with the nuclear medicine guys on the other side of the health authorities and working together to give this treatment. And so far we've treated about 50 patients in the year since we've done this treatment, and it's made a difference. I can already see it does make a difference. It's not a wonder drug, it's not a magic bullet by any means, but it certainly makes a difference. I would say, just anecdotally from the patients I've treated, the ones who respond, they definitely get, while they're on this treatment for 6 months, they enjoy 6 months of relative stability in their cancer. It sort of really slows things down, improves things for that period of time. Eventually, does the cancer start to grow again? Yes, but it's definitely buying them good quality time, good quality life time with the cancer. And then keeping in mind, it's just one of 4 or 5 new treatments we have for this phase of cancer. By kind of sequencing them one by one, overall, I think we're really making a big difference in this population that really needs help. It is very well tolerated too. The most common side effects people get are diarrhea, which isn't common. Some people get a bit of nausea, which is really uncommon. And even though it doesn't generally harm the bone marrow, it's possible that it can. So we do need to monitor people's blood counts. So we do get blood work done a couple of times a month just to make sure that we're not causing any trouble with the bone marrow. So that's radium. I'll stop there for a second if anybody has any questions about that. There was, yeah.
I'm in that situation. My PSA is still quite low, but leukoin is no longer having an effect. It's going up at about, my PSA is going up about 0.5 a month. It's now at about 7.5. I don't think it's metastasized yet. I should have another bone scan, I would think.
Yeah, I mean, in that situation, what your oncologist will probably do is when the PSA gets to a certain level, they'll likely image you again with a bone scan or a CAT scan, and if the cancer shows up in the bones or elsewhere, then you'd be eligible for one of the 4 or 5 treatments that we have for that situation. And radium is just one of them. There are other options still that can be used, chemotherapy, what we call advanced hormone therapies, which are kind of newer hormone therapies that we can use. And so it's really a matter of when you get to that point, if you get to that point where you need one of these treatments, it's a matter of having an open discussion with both the radiation oncologist, the medical oncologist who has access to these other treatments, and kind of coming up with which is the best one for you. We're finding that in the long run, men are usually needing all of the 4 or 5 treatments that we have, and it's a matter of sequencing them properly. Which treatment is best to start with, what order we can give these treatments in. And because there's 4 or 5 of them, we can keep people with this phase of the disease. We can keep a lot of them feeling well for long periods of time. And the good thing is there's more treatments for this phase of disease coming out every year.
So I don't have a radiation oncologist or any contact with the cancer agency.
Mm-hmm.
So I'm sort of waiting until it gets to about 10,
Yeah.
and then applying to get attention.
Yeah, and I think that's a reasonable thing to do. I mean, I hope that you have somebody caring for you, a family physician or a urologist that are keeping an eye on things. And we are always communicating with the family doctors and with the urologists, so they know what to do in these situations just as well as we do. And so presumably they would, wait till the PSA got to that certain level, maybe 10, do some imaging, and then refer you back to the cancer agency.
Right. Thank you.
So the last thing I want to mention is something that we don't have, but it's on my wish list for 2017, and I actually like this. I think it's kind of cool because it's something that's so simple and really makes a big difference. And it's a new product, and what it's called, it's a product called Spacer Gel, is what it's called. And basically it's a product that's been designed to reduce the side effects of external beam radiation treatments for prostate cancer. And so, those of you that have had radiation treatments, you'll know that bowel-related side effects unfortunately are seen with external beam radiation treatments. It's one of the things that does happen to men. In the short term, during radiation treatments, somewhere between 10 to 20% of men will have significant bowel issues sort of during in the months following radiation treatments. And in the long run, unfortunately somewhere between 6 and 15 or 20% of men in the long run will have chronic bowel problems as a result of the radiation treatment. And so that's something that they struggle with. And some of these problems can be, increased frequency of bowel movements, rectal pain, chronic diarrhea. In the extreme, it can lead to obstructions of the bowel that might require surgery or need for some sort of interventional surgical procedure. So these can be quite significant problems that affect a significant number of people. Why does radiation treatment cause these bowel side effects? It's all about location. If you see this is a picture of where the prostate lies in relation to the rectum. So this is the prostate gland here, and right behind the prostate, sitting right abutting the back wall of the prostate, is the rectum. And so when we give radiation treatment, we can be very focused with our radiation treatment, and we can position people great, but we always have to, we can't. We always have a little bit of a margin around the prostate that we treat. So this dotted line is sort of the high dose of radiation. And because of where the rectum sits, the front part of the rectum always gets some radiation, and because it's always exposed to radiation. That's just the way it works. It's unavoidable. And so because of that, when the rectum gets radiation, it puts men at risk for having bowel problems. Because part of it is with the high-dose radiation field. So this company came up with a really simple but I think elegant solution to this problem. Their simple solution, just move the rectum out of the radiation field. And so what they've come up with is a product. And what it is it's a solution that's injected into this space, and then it's injected in a procedure that's very similar to the biopsy. It's a 10-minute outpatient procedure that basically we use a needle and we inject this liquid. And when you inject it, it's a liquid into the space between the rectum and the prostate gland. And it's got one syringe that has this substance in it. It's called PEG solution. And then it's got another solution that goes in the same syringe. And when the two solutions contact each other in this space between the rectum and the prostate, the liquid turns into a firm gel immediately. It's actually really neat. It's this neat chemistry. It's immediately form this firm gel. And what that does is that pushes the rectum back or pushes the prostate forward. Basically what it does is it creates a space between the rectum and the anus. And with radiation treatment, we don't need a lot of space. If this thing can give us a centimeter or 1.5 centimeters of space, then things are different. Basically, we end up in this situation, if you look back at this picture now, with that spacer gel in the middle, now the high dose of radiation, which is this dotted line, is no longer overlapping with the rectum. So now the rectum is not getting any radiation, or virtually not getting any radiation. And so the idea is just move the rectum out of the way of the radiation, and men should get less side effects. Simple idea that's going to make this company a lot of money, because these simple ideas that I think are really elegant. I think these are the neatest things ever. This is how you put it in. Basically, it's someone like me would have an ultrasound probe in the backside, freeze this area, put a little needle into that space between the rectum and the prostate, and just inject this gel, and it just pushes these two organs away from each other. And this is what it looks like in real life. This is before, this is the prostate gland here, this is the rectum here, this is before inserting the gel. Once the gel has been put in, here it is here in the middle, kind of pushing them out of the way. And then the beauty of the gel is it stays in place for 3 months, and then after 3 months it slowly starts to dissolve, and by the time a year has gone by, the gel's gone, so it's not there anymore. But 3 months is a perfect amount of time for us to give radiation treatment and have the rectum and the prostate not be close to each other anymore. And does it work? It does. You know, there's a big study that's been done in the States looking at it, and basically what this shows is, for this study, they were looking at how common it was to get long-term bowel troubles from radiation treatment. The guys who didn't get the spacer gel, they didn't do too bad. 6% of them, which isn't too high, but 6% of them had some long-term problems with the bowels because of the radiation. The guys who got the spacer gel, 0. None of them had any problems. So in my books, that's a win. I mean, that's a pretty big win. And when they looked at the quality of life of the men who had this gel versus not having the gel, the men who didn't have it, their quality of life when it comes to bowels sort of slowly decreased with time afterwards, which is what we see generally. But the guys who got their spacer gel, their quality of life stayed the same because it wasn't affecting their bowels. And for some reason, that we don't know why, for some reason it also seems to help reduce the symptoms of the bladder. For some reason, the men who get this gel also seem to have less problems with the continence in the long run. And scientifically, we don't know why that would be, but it seems to have that benefit as well. So really, I mean, going over the benefits, basically, men have less, who use this product, have less pain during radiation treatment, virtually no long-term side effects in terms of the bowel in the long run, and better quality of life, and it's easy to put in. So really, it's a great option. The problem is it isn't cheap. It costs about $1,400 per product, so per patient. So we're trying to get it. I'm in discussions right now with the company that produces it, hoping to get trained to put these gels in early in the new year, and then it's a matter of us trying to get funding. And so we're looking for funding to try and get at least 10 or 20 initial test cases done before, and then once we get some test cases, if it works out, then we can apply for more regular funding from the agency. So right now we're in the situation of trying to find some money for the initial test cases, but I'm hoping that we should be able to do that in 2017. So that's about all I have to talk about today, but I think in summary, basically 2016 has brought us 2 new prostate cancer treatment options on the island. One is the Prostate Saver, which is a new, highly convenient form of potentially a curative radiotherapy that might be more effective than conventional treatment with less side effects. And then there's Radium 223, which is a new option for men with this castrate-resistant or hormone-resistant prostate cancer that we know does improve survival, reduce bone problems, and helps maintain quality of life. And then in 2017, we hope to acquire this as spacer gel to help further reduce side effects for men undergoing radiation treatment. That's all I have. Thank you very much.
Question, if I may. Part of getting the medical service we like is always cost. Any comment as far as the cost of Sabre or
That's actually the beauty of it. Is,
Radium
the Sabre
223?
is cheaper. So they've done a cost analysis of this over out east, and a regular course of radiation treatment, this is about 37 treatments or 28 treatments, costs cost somewhere in the ballpark of about $5,000 or $6,000. The saber treatments are cheaper, running at about $1,700, $1,800, $2,000. So it is a cost savings in the long run. It did require sort of initial injection of money. But part of the problem is also, one thing part of the problem is how we're reimbursed. At the Cancer Agency, it's kind of a bit of a warped form of reimbursement. The Cancer Agency reimbursements for the radiation treatment department are based per fraction. So the radiation treatment department is given their budget based on how many fractions of radiation treatment people get. So when it's actually a bad thing for our funding, paradoxically, if we go from offering 37 treatments to somebody to offering 5 treatments to somebody, the reimbursement from the province for that treatment goes down. And so we actually, it's warped, really. It shouldn't be that way, but so it's not in the department's best interest from a financial point of view to switch to a lower number of fractions. And we're hoping that will change. We do hope that will change. But it is cheaper long.
And the radium, what sort of cost is associated with that?
That's not cheap. It costs about, I think it's $6,000 a month to be on it, and most men are on it for 6 months. So we're set to be about $30,000 for a 6-month course of it. And that sounds like a lot, it is expensive, but putting it into the context of the other treatments for the same stage of the disease, it's actually relatively cheap. It's unfortunate, we're in a whole new era now with treatments, and some of the costs of these treatments are astronomical, and when you compare the cost of something radium of $6,000 a month to a lot of the new chemotherapy drugs and immune therapy drugs, it's actually cheaper.
Thank you.
Did you say the radiation 223 6-month life, or is it?
It's a 6-month treatment. So it's an injection that you get once a month, and you get it for 6 months, and then that's how long the treatment is given for. We don't have approval to give it for longer than that.
But you can't get it longer than that, or
No, unfortunately,
6 months. And
6 months is all you get, unfortunately, and at the moment, until the data that's out there shows that 6 months helps men, then there isn't any data yet to show whether more than 6 months helps men. So unfortunately, we do get stuck in a situation where I'll have a man who I've had on it for 6 months, and they're still responding to it, and I would like to get more, but I can't. The rules right now are I can only give 6 months of it until there's more data to show that more than 6 months is beneficial.
More questions. Financial, the cost of these treatments. I mean, some of this is early studies, and are these things covered off by Medicare, Blue Cross, whatever?
Oh yeah, this stuff is all. I mean, the costs I'm telling you, the cost that the Cancer Agency pays these things are free. I mean, the saber, I should say, is currently only being offered on study. We're not offering it as a standard treatment. The only way to get prostate saber in BC right now is to go on one of the studies, the clinical trials that we're doing of it. But if you enroll in one of those clinical trials, then it's free, it's covered. And the radiation treatments are covered as well.
I was just wondering, with these external beam radiation treatments, and you're just mentioning about the gel, which is used to protect the tissue after it's penetrated the prostate. I mean, what about the tissue that it has to penetrate to get into the prostate? So you've got that same amount of radiation, even more. It has to penetrate healthy tissue to get to the prostate.
I get what you mean.
So what effect does that have on that?
Yeah, and I get what you mean. It doesn't really work like that. Going back to this, it used to work like that a long time ago, and our fancy treatments don't really work like that. If you look at this picture here, the high dose of radiation is actually only in one spot. And I guess the simple way to describe it is, if I was to treat my prostate gland with just one radiation beam coming at me from the front, then what you're saying is true, right? Because the radiation beam would hit the front of me, and then it would hit the prostate and go right through me, and that's the way it would work. But we don't, the dose, so if I had a single radiation beam hit me from the front to treat my prostate, the dose of radiation at the front of my pelvis would be the same as the dose of radiation at my prostate gland. They'd be getting the same amount of radiation. But we don't treat like that. A simple way to kind of explain it is, we break it up into different beams. So instead of having a single beam hitting me from the front, let's say I have 4 beams, one from the front, one from the back, one from the side, and one from the other side. Now, none of those beams is each of those beams now is only a quarter of the radiation. Do you follow me? And it's only where all those beams overlap in the middle, where the prostate is, where each of those 25% adds up to form 100%. That makes sense? So really, if you look at this picture with my analogy, the 100% of radiation would be here, but up here, you only get a quarter of the radiation. And up here, you only get a quarter of the radiation. Down here, you only get a quarter, here you only get a quarter. It's only where all the radiation beams overlap in the middle where you get the highest radiation. And that's just a simple example of 4 beams. The reality is we're using, dozens of radiation beams coming in from all different angles. So at the end of the day, and it's going at arc. So at the end of the day, the dose of radiation in all of these areas is all very low. The only area where it's high is around the prostate, and just because the prostate overlaps a little bit with the rectum there, that's why the rectal gets that classification. I hope that's clear. Thank you very much. Appreciate it.